Welcome everyone to tonight's webinar. My name is Melanie McKinney and I'm Programs Coordinator for CAN-DO Multiple Sclerosis. And thank you first of all for acting on the belief that you are more than your MS by attending tonight's webinar, which is again Emerging Therapies in MS, and it will be presented by Dr. Randall Schapiro, neurologist. CAN-DO MS is an innovative provider of lifestyle empowerment programs for people living with MS and their support partners. We are the start of a whole new way of thinking about and living with MS. CAN-DO MS empowers people to move beyond their MS by giving them the knowledge, skills, tools, and confidence to adopt healthy lifestyle behaviors, actively co-manage their disease, and live their best lives. In 2010, CAN-DO MS launched its new website, www.mscando.org. And please feel free to visit the website where you can register for upcoming webinars and view our archived webinars. Check out our CAN-DO MS Lifestyle Empowerment programs, including our CAN-DO 4-day programs, Jumpstart and Jumpstart in Motion 1-day programs. You can share your CAN-DO promise and also learn ways that you can contribute to or get involved with CAN-DO MS. And a few items before we get started this evening. As mentioned, questions and comments will be addressed at the end of the presentation. We will answer as many questions as time allows. You can post your question by typing in the chat feature, which is located on the left of your computer screen. And to submit a question, type in the small box that says Chat with Presenters. This will be recorded and it will be archived on CAN-DO MS's website, and you are more than welcome to view the presentation again. We also offer many other archived webinars on our website. And those of you who are attending live tonight, you'll receive an email with copies of the PowerPoint presentation. And you can listen to the live webinar through your computer speakers this evening rather than having to call in. So the job of the live participants tonight is to submit your questions and comments in the chat box. Please complete the evaluation at the end of the webinar and review our webinar schedule, and feel free to register for any upcoming webinars. And we'll have a wonderful presenter tonight, again, Dr. Randall Schapiro. He's president of the Schapiro Multiple Sclerosis Advisory Group. He's also formerly a clinical professor of neurology for the University of Minnesota, now retired. And Dr. Schapiro has been involved with CAN-DO Multiple Sclerosis since it was known as the Hugo Center for MS, and he's been on our program staff for over 25 years. So before we get started with tonight's presentation, we'd like to learn more about you. Let's do a quick survey to get a feel for who's on the call this evening. And I just put the survey up, and it looks like it's overwhelmingly individuals living with MS. So with that, I will turn the presentation and slide deck over to Dr. Schapiro.
Well, thank you, Melanie, and it's really a pleasure to be here tonight and to talk to you about emerging therapies and research in multiple sclerosis. You know, it was in May of 1945 that Sylvia Lowry placed an ad in the New York Times, and that ad said, "Will anyone who recovered from multiple sclerosis please communicate with me?" Sylvia Lowry then founded the National Multiple Sclerosis Society, and her goal in founding the National Multiple Sclerosis Society was to find a cause and a cure to multiple sclerosis. Well, here we are, over 60-some-odd years later, 67 years later, and we still don't have the cause, and we still don't have a cure. But we've come a long way in our journey with multiple sclerosis. I'd like to tell you a little story about a 28-year-old woman who in the year 1944 developed numbness and tingling of the legs. She had double vision 3 years earlier. Nobody really knew what was wrong, but it cleared. But she went to the doctor, and the doctor said, "Let's do a hot tub back test." And so she was lowered into a hot tub of water, and when she came out, she had some double vision for a little bit. The numbness returned, and she was diagnosed with demyelinating disease. The reason it was called demyelinating disease was because the doctors then didn't want to say multiple sclerosis. They felt that that was sort of telling her that her life was over, so they coded it and said demyelinating disease. Well, she did fairly well, but she had problems over the years with bladder difficulties, walking problems, and some depression as well. The problems worsened over the 14 years that ensued after that, And after 14 years, she really couldn't walk very well at all. And in that era, we're talking about the 1950s now, the late 1950s, there were no good lightweight wheelchairs. Of course, there were no curb cuts. There was no ability to be mobile. She had to stop driving at that time. The disease slowly progressed, and eventually she went into a nursing home. She was in her early 60s at that time, and she was in the nursing home for about 17 years, a little less than that. And she died at age 77 of heart disease. And you know, that was back in the 1940s, 50s, 60s, 70s that all of this went on. If it were today, possibly my mother wouldn't have had to go through what she went through back then. So I'd like to tell you a little bit about what's changed and how we've changed and where we're going today. In yesteryear, in my mother's day and age, we made the diagnosis of multiple sclerosis by looking at the clinical picture of the disease. We did a neurological examination. We could do a spinal tap back then, but the results were not very conclusive. Certainly it wasn't very sophisticated. We did this gross hot bath test that was really not of much value. And then we said to people, go home and rest. And those of you who know the history of can-do multiple sclerosis and the history that goes back through the Jimmy Huga Center know that that's what Jimmy Huga was told. Go home and rest. Or in other words, diagnose and adios. Today, it's very different. We still have the clinical picture. We still do a neurologic examination. I'd like to think we do it better, but maybe we don't. But one thing we do better is we have an MRI scan, and we can look inside the brain, and we can see the white spots that you can see on your screen there that are indicative of inflammation going on in the brain that may be multiple sclerosis. Of course, it may be other things as well, but it may be multiple sclerosis. We can do exquisite cerebrospinal fluid testing. That old-time spinal tap has gotten much different. We can evaluate the nervous system with evoked potentials, and we can treat the disease with disease-modifying medications. We have services from the National MS Society, including case management, psychological support, education, equipment help. We have services from the Multiple Sclerosis Association of America, including MRI help and things of that nature. We have symptomatic management. We have rehabilitation and exercise that were developed through can-do multiple sclerosis programs. We have adult day programs. And even with all of that, my mother still might have died at age 77 because that's when people, unfortunately, end their lives quite often. Multiple sclerosis is said by the National MS Society to affect about 400,000 people in the United States. I think that number is absolutely bogus. Matter of fact, I know that number is bogus because that number came from 1975 data. 1975 data. Those of you who know me know that I'm a Minnesotan. I live in Colorado now, but I practiced in Minnesota for over 35 years and founded the first comprehensive MS center in a private practice in the United States back in the late 1970s. In Minnesota, back in that era, 1975, there were 5,000 people registered with the National MS Society. Today in Minnesota, there are over 14,000 people registered with the National MS Society. In 1975, there were 3,000 people in Colorado registered with the National MS Society. Today, there are 13,000 people in Colorado registered with the National Multiple Sclerosis Society. So clearly that number, 400,000, is out of date. And it's really hard to update it because this isn't a reportable disease. Nobody has to tell anybody that they have it, but we should be able to come up with a better number than that. It's said that there are 2.1 million people worldwide. I have no idea. But I do know that this is an expensive disease. And the costs of MS in the United States are over $28 billion a year. The word research comes from the Middle French. It means to investigate thoroughly. The Wikipedia, which has really been our source of interesting information these days, tells us that it is an active, diligent, systemic process of inquiry aimed at discovering, interpreting, and revising facts. There is no question that multiple sclerosis is a complex disease, and it requires a complex approach. I talk about managing MS as being disease management. That's what we'd all like to do, is to be able to change the course of the disease. And for the first time in 1994 or so, we got the opportunity to potentially change the course of the disease when we got the first disease-modifying treatment. And now we have 8 MS-approved treatments approved by the FDA to potentially change the course of the disease. Up until then, the backbone of managing multiple sclerosis was, and still is, the symptomatic management of multiple sclerosis. So we have disease management, symptom management, and we have a person who has the disease as well. So we have to understand that we have person management as well. That's the psychological, vocational, marital issues that people with chronic disease have. Our tools for managing MS include drugs, that's pharmacologic treatment, therapies, that's rehabilitative treatment, and psychological treatments as well. And so if we look at research in multiple sclerosis, we see the areas of research follow these areas: disease management, symptom management, person management, pharmacologic research, rehabilitative research, psychological research. So the areas of research in multiple sclerosis include new treatments. We're going to be talking about that. Genetics, we're going to talk about that. But there's another area that we should also think about, and that is the area of genomics. That is the idea that we could look at somebody's genetics and potentially choose a treatment by their genetic characteristics. Which treatment fits which people at which time? That's an exciting new area that we look forward to seeing more and more research in. We have research into the mode of action of drugs, research into the immune system, research into cell biology. We call it proteomics as well, looking at why a drug may not work in certain people. Virology, remyelination, social and personal impacts of MS. There's rehabilitation research. There's nursing research. There's economic research. And there's symptomatic research. So if you'll bear with me for the next 6 hours or so, we're going to tell you all about these areas of research. No, we're not going to be able to do that. Obviously, we're going to have to limit what we talk about because there's so many areas of research we couldn't possibly handle it in today's talk tonight. In 1981, there were 564 papers, the National MS Society tells us, in the published journals. In 2011, there were 3,619 papers in the published journals. In 1992, there were 0 treatments for the disease multiple sclerosis. Today, there are 8 FDA-approved treatments, with several more just waiting to be approved in the next short time. So for you to understand how we got to this situation, I would like to give you some background in understanding and interpreting research in multiple sclerosis. We are in the era of exploding knowledge, and we got there in the 1990s, and we continue to be there because we learned how to study multiple sclerosis. It is really important to understand the principles that you have to do randomized, double-blind, placebo-controlled clinical trials. Randomized, double-blind, placebo-controlled clinical trials. These are trials in which the investigator doesn't know who's getting the active drug. The patient themselves doesn't know whether they're getting the active drug or a placebo. So a group is getting placebo, a group is getting active drug. They don't know whether they're in which group. We study the details, we break the codes, and we find out. It is important to understand that we need to do randomized, double-blind, placebo-controlled clinical trials. And I hope that you'll enjoy some of the cartoons and humor that we try to put into this. Without hearing your laughter or boos or guffaws, I have no way to feed back on this. You know, the problem with multiple sclerosis is the great placebo effect that occurs in studying it. 65% of the time, no matter what we give people with multiple sclerosis, they will get better. And I mean they actually get better. Their reflexes may get better, their coordination gets better, they look better for a while. The mind is a powerful organ, and it can overcome lots of things for a while. And so we have to do better than placebo because often there's a placebo effect that occurs in multiple sclerosis. If I give people chicken soup with multiple sclerosis, 65% of the time they will feel better. So we have to do randomized, double-blind, placebo-controlled clinical trials. Then we had to learn that we had to look at populations of people with multiple sclerosis. In the old days, we just studied multiple sclerosis. That means that we studied people who were bedridden next to people who were ambulatory. And we didn't have any success in our research in that area. So we learned that we had to divide people up into groups. Why, yes, most of the medical research on your treatments was done by men on men. Has that been a problem, Ms. Pinsky? And you look at the comic there. We had to divide people up into groups, and we divided them up into 4 categories. We understood that 80 to 85% of people with multiple sclerosis began their journey with a fluctuating course. We called that relapsing remitting multiple sclerosis. Over half of them along the way stopped having those relapses and slowly got worse. We called that secondary progressive multiple sclerosis. 10% of people got worse from the get-go, so we called that primary progressive multiple sclerosis. And 5% didn't read the book and started progressive and then relapsed, so we called that progressive relapsing multiple sclerosis. Now, when we divided people up into these categories, we realized that these were multiple sclerosis, all of them. These were patterns of the disease. Now we're beginning to wonder whether there may be more than one disease that's involved here, but that's a different issue that we could handle in a different time frame. But to suffice it to say, by dividing people up in these categories and then studying the easiest category to study, relapsing remitting multiple sclerosis with 85% of the people in that, those people look somewhat alike. And then we could do research on them, and then we began to see success with our randomized double-blind placebo-controlled trials. If you look at who's out there today, we feel that there are about 55% of the people with multiple sclerosis have the relapsing remitting pattern of the disease. 30% have secondary progressive, 10% primary progressive, and 5% progressive relapsing. Who performs research in multiple sclerosis? Well, it may come as some surprise to you, maybe not, that the pharmaceutical companies and biotech companies do the bulk of the research for the clinical treatments that are available for us and that are coming down the pike. Often these treatments start in university laboratories with basic science. They may come from nonprofit research institutions. The National Institutes of Health does a lot of basic research, and there are other non-affiliated groups and individuals. The National Multiple Sclerosis Society sponsors almost all of these to some degree with competitive grants that are peer-reviewed, and so they're the backbone of the voluntary health agency research. The National Institutes of Health has the majority of research. So this is a partnership between pharmaceutical biotech companies, universities, and other research institutions. There are many trials that get done to teach us about multiple sclerosis. The main type of study is called the clinical trial, but there are other studies, including population surveys, quality of life questionnaires, tissue cell examinations, and basic laboratory research. To get a drug to market, it's not a simple procedure. It has to go through a lot of testing, and that starts out with a phase 1 test, a phase 1 trial, if you will. The phase 1 trial focuses on safety. So it may be normal people, normal medical students, normal volunteers, and we see how many people get sick from the drug. What are the basic side effects from it? Is this a safe drug to take into a clinical treatment? That's what the phase 1 clinical trial is about. Then if we pass the phase 1 clinical trial, things move to a phase 2 clinical trial. This is a little bit bigger study. Typically, it is randomized and double-blinded, but it looks at efficacy. But what we're really looking for is what's the right dose? How many people do we need in a real study to see a treatment effect? Are there any new side effects that might be bad? And then if it passes the phase 2 trial, we move into the phase 3 trial, and that's the randomized double-blind clinical trial that we think of allows this drug to see whether it works or not. And if this trial works, the drug is then approved by the FDA, and then we do safety studies on this particular drug. So there's a phase 1, phase 2, phase 3, and then phase 4 clinical trials. It usually takes about 18 years to get through these and billions of dollars. So that is one of the major reasons why these drugs cost so much at first. It costs a lot to get them through safely and make sure they work and make sure there's something to be of value. Well, I want to spend a few minutes and talk about symptom research before we talk more about the drugs that are coming down the pike that may help the disease itself. Now I want to talk about a drug that I did some of the research on. It's called Dalfampridine, 4-aminopyridine. Fampridine, Ampyra is the drug. It's a potassium channel blocker that allows demyelinated nerves to conduct more efficiently. And in 2 randomized, double-blind, placebo-controlled trials, it appeared that Ampyra, which allows demyelinated nerves, I'll say it again, to conduct more efficiently, doesn't change the course of multiple sclerosis, changes the symptoms of walking in over 30% of the people who took it. That means that 2 out of 3 people didn't have an effect on walking, but 1 out of 3 did have an effect on walking. This drug has been long in research, and we know that because it stimulates the nervous system, there's an increased possibility of seizure. So this is a drug that was approved in the past few years. It's here now. We can use it as an approved drug to help people walking. As you know, in multiple sclerosis, we have the nerve. It's called the axon. And that nerve is a highly insulated nerve with layers of insulation called myelin. And what you may or may not know is that the electricity jumps between the nodes that you see on the picture there to get to where it's going. So the brain says, move the right arm. The message goes down these nerves, skipping down them to move the right arm. As you'll see in this next picture, which is commonly shown in multiple sclerosis, and if you look right in the middle of the picture, you'll see the yellow axon covered by red myelin. And then if you look to the right, you see that the red myelin is gone, and you see the axon colored green. That's a demyelinated section of the nerve. And so what the potassium channel blocker Ampyra does is allow the nerve to skip through that, allow the electricity, to skip through that area to keep its power so that it can conduct and help people walk. And if you look above, you'll see that the axon broke, and then it balled up into this green mass. And that's what happens in multiple sclerosis. When that happens in certain areas of the nervous system, a person experiences a stiffness, a spasticity. This word spasticity comes from the Greek word to tug. It's what we call velocity dependent. That is, the faster you move that arm or leg, the stiffer it gets. And it's part of what neurologists call the upper motor neuron syndrome, which I'm not going to get into tonight without being able to illustrate for you. Suffice it to say, we have had drugs for spasticity for quite some time. We've had rehabilitation for spasticity. We've learned how to do spasticity, take care of spasticity better. But in the past few years, we've learned that you could inject Botox into the muscles of the spastic extremity and get them to loosen up. This is good if you have 1 or 2 or 3 muscles that are particularly stiff. And we've been doing it for a while, but now it's approved for use. It lasts for about 3 or 4 months, these little injections, if you will. Now, they're injections into the muscle as opposed to what gets done for wrinkles, which are just into the skin, so to speak. Those muscles look beautiful. They're wrinkle-free right out of the dryer. They look beautiful. So that's here now. We've had drugs for spasticity, as I said, for quite a while, since the 1970s, actually. But now we are, or 1980s, I should say, but now there is some investigation on a longer-acting form of baclofen, basically. It's a longer-acting one by a company called Xenoport. And we look forward to the studies involving that as well. So we see that coming. Marinol, which is a pill-like form of marijuana, if you will, has been studied in spasticity, and it doesn't work as well as the drugs we have, but we know that there are cannabinoid receptors on CNS cells. So there's a different drug that has been approved in Canada and now being approved in Europe and is being studied to be approved in the United States called Sativex. Sativex is a tetrahydrocannabinol, and it has a combination of ingredients. And it helps people with pain from multiple sclerosis and with sleep disturbances. It continues to be studied. There was a recent study just done in Great Britain showing that it doesn't work in all people. About a third of the people drop off of it. But for some people, it provides some reduced pain and spasticity, and that it has relatively few side effects associated with it. But it is an inhaled type of substance, and so the long-term effects on the lung become an issue that we have to understand. Cognition is an issue in multiple sclerosis that occurs in about 60% of people with MS, 50 to 60%. 10% significant problems with memory, planning, foresight, and judgment. We've learned a lot about why cognition occurs in multiple sclerosis. The research into why has told us that not only the white matter is involved in MS, but the gray matter as well. Unfortunately, that hasn't given us the treatment for this. We've tried a number of different medications without much success. Pain is another symptom that's not talked about enough in multiple sclerosis. It occurs in 50 to 60% of people with MS. It's a burning, irritative type of pain, and the routine pain medicines typically don't work in this. We talked about the use of marijuana as a potential helper in this, but that's got some issues associated with it, because if you inhale marijuana, it actually can damage your lungs significantly, and it causes brain shrinking, brain atrophy, even though it may help the pain associated with it. So really, it's not quite ready for prime time. There are a number of epileptic drugs that we use for epilepsy, for seizures, that have shown to be of value in neuropathic pain, including multiple sclerosis, one of those being pregabalin, Lyrica, but there are a whole list of many others that are not approved for this use necessarily, but have studies to show that they are of value in the appropriate person. There is an interesting symptom complex that occurs in some people with multiple sclerosis. We call it pseudobulbar affect. This is an inappropriate laughing or crying that occurs in some people with multiple sclerosis. They may laugh when they should be crying. They may cry when they should be laughing. They may laugh at a funeral. They may cry at something particularly happy and not be able to stop. And what we've learned is that if you mix one of the ingredients in cough medicine, dextromethorphan, that's Robitussin DM, the DM is dextromethorphan, with a heart medicine, quinidine, it antagonizes certain receptors that then will control this pseudobulbar affect that you notice when you think about it, but you don't notice if you don't think about it. So now we're going to move into the drugs that have to do with taking care of the disease multiple sclerosis, moving away from some of the symptomatic research that has gone on. You know, we've done a great job of developing drugs in the past 20-some-odd years. We have 8 drugs that are approved by the FDA that potentially can change the course of multiple sclerosis. We have the interferons, we have glutaminyl acetate, and we have mitoxantrone, and these were drugs in search of a disease. By that I mean these categories were present before multiple sclerosis, if you will. The interferons were used for hepatitis, they were used for cancer, they were used for certain viruses, and then somebody said maybe they will work in multiple sclerosis, and lo and behold, they did to a certain degree, to slow the progress of multiple sclerosis and decrease the relapses occurring with the disease and decrease the MRI activity. Glutaminyl acetate was actually invented to create an MS-like disease in mice, and when it failed to do so, somebody said, let's look at it as a protector for multiple sclerosis, and lo and behold, it became a drug that decreases relapse rate, decreases disease activity, if you will. Mitoxantrone was a cancer chemotherapy drug used for the treatment of many different kinds of cancers, and somebody said, let's use it for multiple sclerosis, and lo and behold, it worked in some people with multiple sclerosis. So we have these drugs in search of a disease. We learned a lot about the immune system in the process. The immune system is a system in the body that fights foreign substances. As you know, in AIDS, the immune system is underactive, and in MS, the immune system is overactive. And it's turning out white blood cells which recognize that myelin is foreign and nibble away at it. Well, we think it's the myelin. It may be something else, but it results in multiple sclerosis. The immune system is located all over the body, and you can see on the picture here, it's in the tonsils, it's in lymph nodes, it's in the gland over the heart called the thymus, it's in the spleen, it's in the lymph nodes of the gut called the Peyer's patches, it's in the appendix, it's in the bone marrow, it's in the lymph nodes in lymphatic vessels, it's all over the body, but you know what? It's not in the brain and spinal cord. It's not there. So for it to get there to attack the nervous system, it has to do some activity to do that. It's not an easy thing. The first thing that has to happen is that immune cell, which you see on the left, that big blue thing there, purple thing there, it has to be programmed to want to attack something that it really doesn't know it wants to attack in the central nervous system. Then that cell programmed gets into the blood vessel. and you can see that Th1 cell getting into the blood vessel there. Once it gets in the blood vessel, it has to get through the blood vessel wall into the brain and spinal cord to do the attack. To get there, it has to go through a blood-brain barrier. It's not easy for it to do that. To get there, it has to be pulled through by an adhesion molecule. So it gets pulled into the nervous system. So knowing this, once it gets into the nervous system, it can then be activated and attacked. Knowing this, the researchers thought, let's develop an antibody, if you will, a bullet, to attack that adhesion molecule and stop that cell from getting through the wall of the blood vessel through the blood-brain barrier. And that adhesion molecule, that substance that does that, was natalizumab or Tysabri. So that's the mechanism of action, if you will, or one of them at least, of natalizumab. It's preventing that cell from getting to the nervous system. Gilenya, fingolimod, our first oral agent that more recently came out, has a little bit of a different mechanism of action, but the same end result. It traps those cells in the lymph nodes. It doesn't let them out of the lymph nodes, at least not very many. If it can't get out of the lymph node, it can't attack the nervous system. And so these drugs clearly work to decrease relapses and slow the progression of multiple sclerosis. But our bodies weren't made to have cells not get into the nervous system. We need some cells in there to protect ourselves, to monitor for viruses and cancers. And so when we keep these cells out of there, we open up ourselves to having other diseases that we may not have had before. And one of those diseases occurs from a virus called progressive multifocal leukoencephalopathy. That's the disease. The virus is called the JC virus. PML, progressive multifocal leukoencephalopathy, is associated with Tysabri in some people who are sensitized to that virus. That's a risk that we didn't have before. That disease is terrible. So as we see the newer drug treatments come forth, we have to recognize that they come with certain risks to get certain benefits. And it becomes important that doctors who treat people with multiple sclerosis and people who have multiple sclerosis recognize the risk versus benefit ratio of each drug that they take, no matter for what. Is it worth the risk to get the benefit? Sometimes it is, sometimes it may not be. It's important for us to recognize that so we don't come up with diseases that are worse than multiple sclerosis. Gilenya has some issues as well involving the heart because there are receptors to the inhibitor that it is in the heart, and that is a risk that we have to watch for. Is it worth the risk versus the benefit? So as we look at the treatments of tomorrow, we are always asking ourselves, is it worth the risk versus the benefit? So let's start out with three that are likely to be coming to the FDA in the next year to year and a half. One of these is called BG12, or fumaric acid ester. It upregulates the response of the good part of the immune system to keep these cells from attacking the nervous system. We don't know entirely how it works. It was used, a form of it was used by some people in Europe for the treatment of psoriasis. In very well done studies thus far, it appears to be a good candidate to be an oral treatment with relatively low risk thus far seen. But we have to keep our eyes open when we have a new drug used in a new way over a long period of time, because that's one of the issues in multiple sclerosis. You have to keep taking these medicines over a long period of time. So we look forward to seeing fumaric acid esters, BG12, come through the FDA. Another oral drug that works on a different mechanism of action, inhibiting pyrimidine synthesis in T cells, is terflunomide. Terflunomide comes with studies comparing it to interferon, which shows that they work about equally in terms of potency. Terflunomide comes with a different set of side effects that we will have to see how they work over time. We worry about such things as getting pregnant on terflunomide and hair loss with terflunomide. But time will tell, and the studies will show us whether that risk is something we need to pay attention to or not. So that's coming to the FDA. A third drug, which is quite different, is this intravenous medicine called Campath or alemtuzumab. It's not going to be called Campath in multiple sclerosis. That's the name it was called for the treatment of cancer, of leukemia, of B-cell leukemia, if you will. It targets certain lymphocytes to knock them out. It is quite potent. It is quite effective, but it comes with quite a lot of potential side effects involving the immune system, including malignant thyroid disease, as well as a disease in which your platelet count drops. And there are other issues as well that occur potentially with alemtuzumab. But it is quite potent. So when we need a potent drug because the disease is getting way out of control, it will be nice to have a bullet in our armamentarium for that type of process. So these are three that are actively working their way through the FDA as we speak. Maybe in the next 6 months to a year and a half, we'll see the answers from the FDA. But there are others. There are others. We learned a long time ago that we could take the potent cancer treatment, cyclophosphamide, and knock out the immune system and take the person's own bone marrow stem cells, clean them up and transplant them back in and slow the disease down. But that's a very difficult treatment. It's not something we're going to do routinely, but studies continue on that. There is a different approach where somebody's immune cells are taken out and then antibodies are made toward that, and a vaccine is made toward that. It was called Tovaxin, but now in Europe it's going to be called T-Cellna, the T-Cellna, and the idea being that you will have personalized treatment toward your multiple sclerosis. The drug laquinimod is a relative of a drug that we researched many, many years ago that had too many side effects. It has been studied in multiple sclerosis and shown to have an effect, but not as much of an effect as maybe desired, but more studies are being done on it, and we look forward to seeing what happens with that in the future. That's an oral drug as well. Now, we know from genetic studies that there are certain cytokines. Cytokines are hormones of the immune system, if you will, hormones, and these hormones are sometimes seen in bigger numbers in multiple sclerosis. And one of those hormones, cytokines that we see that is outstanding in MS is a cytokine called interleukin-2 or IL-2. And daclizumab limits the T-cell expansion by blocking signaling of this particular cytokine. So that is being studied in multiple sclerosis. We've known from previous studies on a drug that was developed for rheumatoid arthritis called rituximab that if we knock out the B cells, that we can slow the disease down. But rituximab is made from a mouse antibody. And so it's a humanized mouse antibody. So now there's a humanized human antibody called ocrelizumab, which is very similar to rituximab, and that's being studied in multiple sclerosis. In Europe, there's a new formulation of Rebif, interferon beta 1A, that is available, working its way in research studies. And the concept of high-dose vitamin D, or whatever dose of vitamin D, is fascinating because, as you know, most of you know, as you move away from the equator north and south, we typically see a bit more MS. We're in a mobile society, so that's changing. But it appears that that may have something to do with not only the genetics of the people who live there, but also with their vitamin D levels. And so we're getting research in vitamin D levels that tell us that maybe if we treat people earlier with vitamin D, maybe we could prevent or slow or do something with the disease. It's too early to tell, but that research is certainly exciting. Throughout all of this, we ask ourselves the question, what is the antigen? By antigen, I mean, what is it that's being attacked in multiple sclerosis? Why is it that that immune system is turning to attack something in the nervous system? What is it that it's attacking? Is it the myelin? Is it the axons? Is it something else? It may be those potassium channels. There are studies that tell us that those potassium channels that we talked about with the drug Ampyra or Dalfampridine may be involved in multiple sclerosis. So what is the antigen? We continue to look for that. And we know that MS is not a hereditary disease. You don't inherit the disease. But clearly you have to have the immune system that lets you to get this, lets you get MS. The likelihood of getting MS just out of the air is about 0.2%, 2 out of 1,000. But if your mother or father has MS, and if you're a woman, the risk jumps to 4%. If you're a man, it's less. It's 2%. That's very low, but it's higher than 0.2%. If your identical twin has MS, the likelihood of you getting MS is 30%. That's not low, but if it were hereditary, it would be 100% because you share the same genetic profile. So we know that there's a genetic aspect to multiple sclerosis. You probably inherit that immune system, but what do you inherit? You inherit an increased susceptibility on chromosome 6. That has been very clear for a long time. But now that we know the whole human genome, we've discovered there are linkages and genes in some other chromosomes that have the potential, albeit in a minority of individuals, to be associated with multiple sclerosis. We're learning more. We're learning more. Stay tuned, because as we learn more, we may learn which genetic people will respond to which drugs, which genetic people won't respond to which drugs. Well, we've learned a little bit how to slow the disease down, but we'd like to learn how to remyelinate the system. And we know that our nervous system is made originally from stem cells. These stem cells are programmed to make nervous system cells. It turns out that adult stem cells are programmed to make whatever they're programmed to make, and we can't get adult nervous system stem cells. Most of them are blood stem cells. And so to take adult stem cells and say, make a nervous system, we don't have any success. But if we take stem cells from embryos that are about to be thrown away from fertilization clinics, we can, in fact, program them to make myelin and make nervous system. Not repair multiple sclerosis yet, but maybe in the future. So I want you to understand that there are stem cells that are pluripotent. These are stem cells that we can direct to make whatever we want to. There are stem cells that are multipotent. These are designed to make what they're already set to make. So we want pluripotent stem cells, and these stem cells look like balls of tissue. They're just cells. There's no hands or arms. One in the picture here looks like a rooster, but that's just randomized. They're just balls of cells that are going to be thrown away. So we're looking forward to research on stem cells to potentially remyelinate the nervous system in the future. We've known for a long time that something has to trigger that immune system. Maybe it's a virus. We thought we knew the virus in the 1970s. We thought it was the measles virus. In the 80s, we thought it was the herpes virus. Then in the 90s, we thought it was the retrovirus, like similar to the AIDS virus, but a different retrovirus. Then we thought it was the herpes 6 virus. Then we thought it was chlamydia bacteria, and today we think it's the Epstein-Barr virus. And so research is being done into viruses, and we'll look at that. And research is being done into complementary therapies as well, such things as yoga, such things as diet, things of that nature. This research is important to do. We did a research on prayer in multiple sclerosis. It was a randomized, double-blind, placebo-controlled trial on prayer. You might think that was easy to do, but it wasn't. It wasn't easy to do at all. We did this in conjunction with the School of Public Health at the University of Minnesota, and the first issue that we had is who should do the praying. Are all of our prayers equal? Well, some people think so, but we have people who do professional praying, and they think their prayers are more important. We were in Minnesota, so we thought maybe the Lutherans would like to pray, but they didn't want to. We went to many Lutheran churches. They didn't want to get involved in this. But the Sisters of Perpetual Adoration out of La Crosse, Wisconsin, they weren't afraid, and they participated in our randomized, double-blind, placebo-controlled trial. I'd like to tell you that it all worked out, and the people who got prayed for did much better, but in fact, it didn't work at all. But we have to do treatments like that, or studies like that, in order to understand where we're going. So studies on acupuncture and things of that nature become important. So in summary now, we've come a long way with research of many types. The future looks bright, but the present is not so bad either. And so now, Melanie, I will open this up for questions. I'll let you screen or do whatever you want with these questions. I'm happy to answer any question that anybody wants me to answer.
Oh, certainly. Certainly. And I apologize in advance.
And by the way, the person who spelled complementary spelled it wrong here.
Oh, goodness.
It's not complementary.
But, yeah, we have gotten some great questions here. I'll just kind of start randomly going through the list here. With vitamin D, are are you able to kind of speak to some of the research that's being done with that?
Sure, I can. You know, it's an interesting story, the vitamin D story, and it makes some sense in many different ways. And there were some studies done from veterans and from nurses as well, 2 different study groups, where they had vitamin D levels. Somehow they obtained these long ago. I don't know how they did it or how they lasted to be preserved so long, but the people who did these studies with fairly good numbers were able to show that the people who had lower vitamin D levels at the time of entrance into the military or the time of entrance into nursing, if you will, had more of a likelihood of getting multiple sclerosis than the people who had higher vitamin D levels. Now, these have to be replicated in a prospective way. Those were what we call retrospective studies, and they have lots of issues associated with them when they're looking back to see. So now we have to do prospective studies. But the question comes up, what if we give people vitamin D? If vitamin D is a fat-soluble vitamin. Theoretically, we should be able to overdose with vitamin D, but it appears that it takes a large amount of vitamin D to overdose on it, and so vitamin D is available everywhere. And so maybe it would be a good thing to take and as a preventative, and we don't know the answer to that. But it certainly seems safe, and it's not expensive. So studies are being done. Now, I'll tell you that I'm excited about the prospect of vitamin D studies, but I would be more excited about it if vitamin D wasn't being implicated in virtually every disease that we don't know the cause of. So pancreatic cancer, people are saying it's vitamin D. Parkinson's, people are saying it's vitamin D. Alzheimer's are saying it's vitamin D. And my gut logic tells me that if it's good for everything, it's probably good for nothing. And I saw that already in many things. As some of you will remember, vitamin C was the answer to everything. Vitamin C, the answer to everything. But now it's pretty much the answer to not too much, except in some people's minds. Then it was vitamin E. Vitamin E was the answer to everything, and actually studies have shown that high doses of vitamin E can be detrimental to your health, not good for your health. And then it was omega-3, and somebody asked a question about omega-3 I see here as I just scanned it. Omega-3 was the answer to everything, but our studies don't show that, actually. It appears that omega-3 may be of some value in some ways for heart disease, but doesn't appear to be much value in multiple sclerosis studies at all. So we have a history of things becoming very popular, seemingly good, and then some of them just disappearing. So I'm excited about vitamin D now, but I withdraw my final conclusion till we get really good studies and see if it works. But boy, wouldn't that be nice? It sure would be nice.
Great, thank you so much. The next question I have, this is someone who's newly diagnosed. Would you advise, and I'm sure this person should speak with their doctor as well, should they wait for a newer medication such as BG12, or is it best to begin with a different treatment right
Well,
away?
you know, that's true. Everybody needs to talk with their doctor about their disease, and everybody is different. And you know, there are 20% of people with multiple sclerosis who will do well with nothing. With nothing, they will do well. 20%, except we don't know who they are at the time of their diagnosis. The only way we know is 20 years later they've done well and haven't had anything. And so we don't see them anymore, but I saw them when I was practicing over the years. And so we have to look at each individual person and try to choose the right drug for the right person at the right time. And that's why having a number of different drugs to choose from is really good if the doctors know the difference between them and know the difference between who should be on taking the risk versus the benefit. So that's when you're a newly diagnosed person, you're wondering, should I wait or not wait? You don't know whether these drugs are going to get approved. We've had many that have failed to get approved when we thought they were going to be approved. But you have to weigh the risk versus benefit of doing nothing and waiting and seeing versus waiting for something that you're not sure about. You know, when these new drugs come out, just because they're new doesn't mean they're better. There's nothing that says they're better because they're new. They're just new. And that's where the doctors have to look and say, which drug is right for which person at which time. Some of the older drugs may still do just as well as the newer drugs, if not better, with less side effects. We don't know until we have experience with them.
Great. Another question I have here is, do MS specialists believe that there is a remyelination drug?
No, there is no remyelination drug as yet. there are a lot of drugs that say that they're trying to be what we call neuroprotective, that is to protect the nervous system. There are lots of things that we're looking at to try to stimulate remyelination as opposed to just as the stem cells which remyelinate, but they're not available to us as yet. So the nervous system can remyelinate itself to some degree. It's a whole other topic, if you will, of talking about the oligodendroglial cell. If you can say oligodendroglial 3 times, you don't have multiple sclerosis. But it's another topic of how we stimulate these oligo cells to make myelin in the nervous system, and we haven't gotten to that degree of sophistication as yet.
Great, thank you. Another question I had is someone's asking about, and sorry if I'm pronouncing this wrong, antilingo, wondering how does it work, effectiveness, availability.
Well, it's not available. Antilingo is one of the central nervous system substances that has to do with demyelination and remyelination and neuroprotection, if you will. And so when we see the nervous system break down, we try to put the chemical components and separate that out and separate which ones are positive ones and which ones are negative ones, which ones can we stimulate and which ones do we want to suppress. And so that opens up a whole area of basic research which is not quite ready for prime time yet. It's really interesting, but it's not ready for therapeutic use yet.
Certainly. Another question is, I have heard that Noventrone is considered no longer safe to use for MS. Is this true?
Well, it's all about risk versus benefit. Noventrone is a risky drug. A certain percentage of people with Noventrone will develop leukemia, and that's not a good thing to have. But Noventrone was never used for people with mild multiple sclerosis. It was always used for people who had significant disease that was getting particularly worse. As a matter of fact, it's approved for what is called worsening multiple sclerosis. So its popularity dropped as we got newer drugs that keep people from getting to that stage. But if somebody gets to that stage of, quote, worsening multiple sclerosis and the tide hasn't been stemmed in those particular people, it is something that their doctor might still want to consider. But its use has dropped out in popularity, in all honesty, when better drugs came forward.
Thank you. Another question here is, I guess in an earlier presentation, you had mentioned that MS tends to exhaust itself in individuals in their 60s or 70s, and this person's just wondering if you could expand on that.
Well, this is an opinion of Randy Schapiro. This is not necessarily shared by everybody, but it's shared by a large number of experienced neurologists, that every disease of the immune system tends to burn out, to slow down in people when they get in their 60s, not 50s, but 60s and 70s. That's not true of everybody. I've diagnosed multiple sclerosis in people in their 70s. That's clearly unusual. I've had people whose disease clearly activates as they got older. That's clearly unusual. But most people, as they get into their 60s, their disease, their immune system tends to poop out, whether it's rheumatoid arthritis, whether it's lupus, whether it's scleroderma, et cetera, et cetera. And that's true of multiple sclerosis as well. So knowing that, we have to make some decisions when we see an individual person. And those are decisions that their neurologist has to make with them to decide which drugs to take and when, maybe when to stop a particular drug, etc.
Great, thank you. Another question I have here is, can you speak to the research going on for the PONS device?
For the which device?
It's PONS device.
Oh, there's a device that is being researched at the University of Wisconsin. I hope that this is what the questioner asked me. That has to do with the innervation of the tongue. And it's a stimulating device that people have found in research. This is preliminary research. Again, this isn't ready for prime time quite yet. But when this device is turned on and stimulates the pons, the area in the medulla, that where the nerves come out to go to the tongue, if you will, that people's strength improves and they do better. I'm not sure how practical this is going to be. It really won't change the disease course of multiple sclerosis. It may be something that we could use for the symptomatic treatment. I wait for more studies, better studies, before I get enthusiastic about that.
Great, thank you. Another question, I've had a couple of people ask about updates on specific clinical patterns of MS, PPMS and PRMS. I don't know if you could just give just a quick overview of things that might be available or in the pipeline for. Well, I know that's a general question.
Sure, that 80 to 85% of people with multiple sclerosis are in the category of relapsing remitting and secondary progressive. That means that 15% are in the other category, if you will, primary progressive and progressive relapsing multiple sclerosis. Let's just think about just progressive multiple sclerosis for a little bit. All of the drugs that we have available and all of the drugs that are pending approval are for the relapsing forms of multiple sclerosis. That's because they were studied in those forms. There have been studies in the more progressive forms of multiple sclerosis, and those studies were not very optimistic and turned out statistically to not show an advantage to a particular drug. However, in each of these studies, there were a group of patients that were progressive that clearly responded to the treatment. This is where the genetic studies become important. Why did those patients respond to the treatment? There weren't enough of them in each study to make the study positive, but there were enough to say there's a glob of people in each study that would respond to a particular drug. So it is now a major force or major plan of the MS Society, goal, if you will, of the National MS Society to find a treatment for more progressive multiple sclerosis, be it secondary progressive, be it primary progressive, be it progressive relapsing multiple sclerosis. And so there are studies that are being done in this group of patients, and we await those kinds of results. As I said, there were studies done that showed some signs of positivity, but not enough to make it worthwhile. We need to expand on those. So as we look to the future decade, I look to see lots of progress in these progressive forms of multiple sclerosis. There is a double entendre for you.
Wonderful. Thank you. Another question I have is, what are some long-term effects of Avonex use? Are there any studies on that?
Well, it's hard to do long-term studies on any of the interferons. And there were studies done on Avonex, and there were studies done on Rebif, there were studies done on beta-seron. All of the interferons, Xtavia is the same as beta-seron. All of these have had long-term studies, but they weren't good enough for the FDA to say, oh, there's good long-term safety. But I think we can take a step back and recognize that we've had these drugs for, 25 years or so, and that their safety has not been called into much question. They're pretty safe, the interferons. How do they work over the long term? Well, it's really hard to know because MS has changed as we've treated people earlier and earlier. But those of us who have treated people for long periods of time can tell you that our units in the hospital that used to be full of MS are empty of MS today. When we go to meetings, the wheelchairs are diminished considerably compared to the past. And so I can tell you that I can't tell you positive long-term studies on any of these drugs, even though they've been done. They've not been approved by the FDA for their label. We're not talking for any pharmaceutical company here. So I can say that they're there and that they're quite optimistic. But the fact of the matter is our life experience tells us that their safety is good and their efficacy is up to each individual person. And we have to look at each person and say, are their relapses diminished? Is their disease slowed down? Is their MRI quieting down? What's happening with them in terms of side effects and quality of life? And if it's a good thing, then we keep the drug going. And if it's a bad thing, then we have to look toward changing the drug.
Great, thank you. I think we have time for just one or two more. I have a question here. It's related to the clinical trials. Why do so many trials restrict participants to limited age groups?
Well, that's designed for several reasons. Number one is they want to get people who are in the MS age group, obviously, because that's how they can get the best results toward the trial. People who are elderly and very young have oddball disease, unusual disease, and that's not what they're trying to study. So they're trying to study people in the MS age group, so to speak, because that's what the drug is designed for. Also, as you get older, you start getting other diseases that start coming into play, and it's heart disease and kidney disease and cancer and things, and that will screw up your studies. And so really it's a pretty practical thing in doing studies. as the bank robbers used to say, you go where the money is. And when you do research, you go where the disease is. And you try to design your studies so that it will have the best chance of showing a positive, an honest positive effect. And so you don't want to have it all screwed up with lots of exceptions, so to speak. Pretty practical.
Wonderful. Thank you. Just one last question. How common is dizziness in people with MS, and is there any treatment for that?
Dizziness is quite common in people with MS. Numbness, tingling, blurred vision, dizziness is quite common with people in MS, and I want to make the comment that it's also quite common in people who don't have MS. Dizziness is so common that there are special clinics around the country called dizzy clinics or vertigo clinics or dizziness clinics. And in fact, I ran one when I was a youngster in neurology for a number of years. That was 30-some-odd years ago. That's how common dizziness is. So when we have somebody who has MS who has dizziness, we have to look and say, is their dizziness due to the multiple sclerosis, or is it in fact due to something else, be it something in the ear or something in the brain or something in the eyes or something in another system some way. Once we've determined that it is multiple sclerosis, the treatment is varied. We may start out with treatment with steroids. If it's acute dizziness, we'll give people high-dose corticosteroids to calm things down, and usually we can. We may use an anti-vertiginous drug such as meclizine to do this. We may use a drug called that people know as Valium, diazepam, which is a direct vestibular, that's in the inner ear, suppressant. And we try to stabilize the dizziness in many ways. But we need to know the cause of it in order to work to decrease it. So it's one of those symptoms that we can treat. It's one of those symptoms in this terrific book called Managing the Symptoms of Multiple Sclerosis. I think I wrote that book, Melanie, and I think it's available in its 5th edition.
Thanks so much, Dr.
By the way, there is another terrific book that people should look into. It's called The Can-Do Multiple Sclerosis Guide to Lifestyle Empowerment, edited by our own Patricia Kennedy. And this book is hot off the press, and it talks about how to improve your lifestyle and be empowered. The Can-Do Multiple Sclerosis Experience, and I can highly recommend this book to people as well, from Demos Health. And available on Amazon.com, but available from probably Can-Do Multiple Sclerosis and Demos Health.com.
I just wanted to let everyone know that wasn't rehearsed. I was actually going to talk about the book, but Randy beat me to it and did a great job. So thank you so much, Dr. Schapiro. I really appreciate that. And Dr. Schapiro contributed to this as well, and we're all very proud of it and very excited. So thank you so much. And there is more information on our website, again, mscando.org, and there's info on the book under the Programs tab. So, yeah, please, and feel free to contact me or anyone else with Can-Do MS for information. I'm just going to go ahead and get to the next webinar topic, which is going to be on September 11th at the same time. It's 8 p.m. Eastern Time, and the topic is In the Kitchen with MS. Our presenters will be Denise Nowak, a registered dietitian, and Ann Mullinex, an occupational therapist.
And
So
I might add
join
that Ann Mullinex is one of my kids, and so you really need to listen to her.
And she's wonderful. They both are. And so, yeah, please join us that evening from your home and office, no charge, for an in-depth discussion on topics. And these vary from exercise, nutrition, communication, symptom management, and total health, and emerging therapies. So this unique webinar series will provide insight from more than one MS expert so you can gain additional knowledge relating to MS. Interact with our team of Can-Do MS consultants, ask questions, and learn how to adopt healthy lifestyle behaviors, actively co-manage your MS, and live your best life. And you can register for this upcoming webinar and other webinars at www.mscando.org. And for those who participated live tonight, once the presentation is over, you'll see a survey appear on your computer screen. And if you could please take a moment to complete the survey, it helps us to continue to improve our webinars, and we value your feedback, your input, and it really helps us in the long run. You'll also receive a copy of tonight's webinar slides by email. So thank you so much again to Dr. Schapiro and to everyone attending this evening. Take care.